Good evening, everyone, and thank you for joining our TIF Talk. My name is Lynn McFadden. I'm with Endogastric Solutions, and it's my pleasure to welcome my colleague Karen Girth to the session tonight as well. Hi, Karen. Our special guest speaker this evening is Dr. Jatinder Pruthi. Welcome, Dr. Pruthi.
Thank you, Lynn.
And along with us is Dr. Pruthi's patient, Delilah. She's coming to share her story about her reflux journey and having the TIF procedure only a few months ago, huh, Delilah?
Yeah, less than 3 months ago.
Wonderful. Thank you all for joining us. I'd like to first let you know that this is a live Facebook event, so please feel free to post any questions you have in the chat session or chat segment of the session, and we'll do our best to feed those to Dr. Pruthi and or Delilah during the segment. I also want to take a brief moment just to give a proper introduction to Dr. Pruthi, so you all know his background. Dr. Pruthi has been practicing as a gastroenterologist now for over 20 years. He graduated from the prestigious Government Medical College in Patiala, Punjab, India, and completed his residency in internal medicine at York Methodist Hospital in Brooklyn, New York. He then went on to complete his fellowship in gastroenterology that included advanced training in therapeutic endoscopy, ERCP, and transplant hepatology at the Los Angeles Medical Center. So again, welcome to our TIF Talk this evening, Dr. Pruthi, and thanks for being here.
Thank you for the kind introduction, Lynn.
You bet. How about we launch the session tonight with you just giving us a medical definition of what GERD is, so folks on the session can understand that a little better.
Yes, GERD stands for gastroesophageal reflux disease. It's a process where the gastric stomach contents back up in the esophagus and they regurgitate up, and then it can be acid or any alkaline contents or any kind of content that backs up in the esophagus is called gastroesophageal reflux disease. It happens because this junction where the esophagus and stomach meet, normally there's a sphincter called lower esophageal sphincter. So that opens and relaxes to let the food into the stomach. So when we swallow food, we eat food, it goes from the esophagus through this lower esophageal sphincter into the stomach, and then sphincter closes again so that nothing backs up. But if that sphincter is not working properly, it remains open, it relaxes too much, or there is some anatomical problem has happened, then the contents from the stomach back up in the esophagus, and then patients will come with the reflux symptoms.
Okay, wonderful. Thanks for that definition. So can GERD ever go away on its own, Dr. Pruthi?
No, because the problem is mechanical. No? So the sphincter is weak, acid keeps backing up, so they will require some treatment. So the symptoms are they'll come back with acid reflux. A burning sensation. A lot of people will say burning sensation happens. Acid burns the esophagus. They'll feel hot in this area, or they may have pain because when the acid backs up, it may cause the esophageal spasm, and that can cause pain. Or the acid backs up and they burp. Sometimes the acid fumes rise up, and they inhale those, and people can come with asthma. And if the acid backs up too much, even people can come with hoarseness of the voice, or they can come with dental caries. A lot of people who don't feel acid reflux, heartburn, typical symptoms, and they end up with the ENT specialist for hoarseness of the voice, and then they go and they check it out. They say, oh, go back to gastroenterologist and see if there is acid reflux happening, so how can we fix them? So the short answer is no, it's not going to go away by itself. Either we take care of the medicine. If we take care of this disease process with the medicine, or we do something to fix the mechanical defect.
Right, thank you. And thank you for covering some of the typical and atypical symptoms that people might be experiencing. So if someone has reflux or GERD, how is it that they are typically managing that?
Actually, a lot of people have acid reflux symptoms. About 40-50 million people in this country have acid reflux symptoms. And heartburn happens with many things. So how people manage them, normally, they will try to avoid things which cause the acid reflux, which make their symptoms worse. Commonly, those are, acidic foods, fatty fried foods. Examples like anything that's fried and cheesy and creamy, or they have the tomato sauce in there, and if they have carbonated drinks, they're drinking or coffee, alcohol. So these things make the symptoms worse. And people, as with they have the disease process, they get experience, so they try to avoid these things and try to control their symptoms. So lifestyle modification goes so far, and plus it's difficult to maintain the lifestyle modification all the time. Then next step comes, they try to take some over-the-counter acid reducers, some like which are the medicines which will neutralize the acid. Some medicines will reduce the acid production, so they are over-the-counter products. People take those on and off, and then finally they check with their primary doctors. They get the prescription acid reducer medicines, and then those don't work after a while. Then they refer to a gastroenterologist. So by the time they come to us, so they have already tried so many things, and they're looking for something concrete. So how are we going to help them to take care of their disease process and prevent all the complications?
Right. So those lifestyle modifications, diet, exercise, and all those things, including the PPI medication management, oftentimes when those aren't working or working long term, it's time for folks to maybe seek another option or another intervention. And so we talked a little bit about those types of methods to manage GERD. And we'll talk a little bit more about procedural interventions in a second. But can you tell us a little bit about what's involved in the diagnostics? So how do people know they actually have GERD versus just a cough or something that they might otherwise ignore or not put a lot of weight into? What would they do to go through the diagnostics to find out?
So first of all, the symptom, if they have typical symptoms, then it's pretty simple. They take the medicine for acid control and the symptoms go away. So that means there is therapeutic test has happened. Okay, there is reflux. Then atypical symptoms may not respond to typical PPI therapies quickly. When they come to us, then we do the diagnostic testing. So first test is endoscopy. So we do EGD, that is, they are empty stomach overnight, come to the endoscopy center or the hospital. So we have a long tube with a video camera on the tip called endoscope. We go through the mouth and take a look. That tells us if there's a damage going on to the esophagus lining in terms of acid reflux. Acid, as the acid backs up, it irritates the esophageal lining, and it can cause erosions or ulcers or stricture formation. It can narrow, or the lining changes into Barrett's lining, which is precancerous condition. So this gives us a lot of information about just visually looking at it. And then we can take a little tissue sample called biopsy sample, look under the microscope and see how much damage is going on. Then we can measure the amount of acid backing up. It's a pH test where we can attach a little pH sensitive probe to the distal lower esophagus, about 6 centimeters above the lower esophageal sphincter, and then we send that monitor home with the patient and monitor them for 96 hours or 48 hours. And that tells us objectively how much acid is backing up, and then we can correlate with the symptoms, and that gives us information at what time of the day acid reflux is happening. it may be happening at nighttime or after you're taking food or all times of the day. So we can calculate a score to find out objectively, what the severity of the disease process is. And then there are other tests we can do to measure the esophageal motility, whether esophagus is moving properly or not, or clearing the acid. So these are some advanced tests that we can do to grade the disease process.
Wonderful. Thank you for that. In that assessment, are you also looking for a hiatal hernia? A lot of folks come to the table asking about what role a hiatal hernia could play in reflux and GERD.
Well, I'm glad you brought up the hiatal hernia topic. Thank you for that. Let me explain what hiatal hernia is. So normally we have esophagus in the chest and the stomach is in the abdomen. And at the junction of abdomen and chest, there is a muscle called diaphragm. So that's a muscle that separates the chest and the abdomen. And the esophagus travels through the diaphragm muscle into the abdomen. So that is called as diaphragmatic hiatus, opening in the diaphragm. Hiatus means opening. Now, if that hiatus, the opening is bigger, is wider than usual, and the stomach tends to move up into the chest. So that is called hiatal hernia. The stomach is herniating into the chest through the diaphragmatic hiatus. Now, depending on the degree of the width of the diaphragmatic hiatus, the degree of hernia happens. And then, a lot of times 3 centimeter, 4 centimeter, 5 centimeter, many times, whole of the stomach can be moved up into the chest also. So that is hiatal hernia. Now, if that happens, the acid gets trapped into the hiatal hernia in the chest, and that it can erode the lining quickly and cause burns, acid burns, erosions, ulcers, which can bleed and cause pain. If that is a condition, then temporarily we can control it with medicine to reduce the acid production. But ultimately, we have to fix the hiatal hernia, bring the stomach back into the abdomen, and fix it there. Make the diaphragmatic hiatus, the diaphragmatic opening, smaller so that the stomach doesn't back up into the chest.
Excellent, thank you. Karen, I think we'll pause here for a minute. There are some questions coming in the chat. I'll address some of those quickly, and then we'll introduce Delilah to tell her story as well.
Wonderful, thank you. I do have a couple questions around PPIs and medications. One of the questions is, are there medications that cause GERD symptoms to get worse?
Certain medications which can reduce the lower esophageal sphincter pressure, those can bring about the acid reflux symptoms and make them worse. Example is antihypertensive medicine for the blood pressure people use is calcium channel blockers, which can reduce the lower esophageal sphincter, and the acid reflux symptoms can get worse. Yeah. So that's one of the things that people who are on a lot of these medications, they're on polypharmacy. So I always review their list of medications and see if something is making their GERD symptoms worse.
And then we have another question. The question is, I have found that PPIs reduce pain, but not the vomiting. Do you feel like a diet change would curb these side effects, or is much more needed?
So PPIs are the medicines called proton pump inhibitors, which inhibit the acid production. So they lower the amount of acid that's produced in the stomach. So there is less acid in the stomach, so the less acid will back up. So when there's less acid backing up, then people will feel better, because when the acid backs up, it can cause the esophageal spasm and the pain. So now the regurgitation part is a mechanical problem, because the sphincter remains open, diaphragmatic hiatus is open, sphincter is not closing properly, and things keep regurgitating. Whether there's acid or not acid, if the sphincter is open, the door is open, they'll regurgitate. So that's why PPIs are not going to help with the regurgitation. And the diet.
And then I have one
the
more
other thing was the diet. Yeah, the diet will not help much with that regurgitation. Whatever you will eat, it can back up.
And I have one more question. This person is having acid reflux more since they're taking Norvasc.
Norvasc. That is the example I gave. That's the medicine that will reduce the lower esophageal sphincter pressure. It's a calcium channel blocker for high blood pressure.
Perfect. Well, somebody watching is taking it, and it is definitely giving them more acid reflux. I'm going to turn it back to Lynn. We do have one question that I'm just going to throw out there. And I know Dahlia, once she's introduced, will talk about it. But people are wondering, at what moment did you decide to see a doctor and have the TIF procedure? So as you're telling your story, people are wondering what kind of made you take that next step.
Yeah, thank you. Thank you, Karen. Delilah, just real quick before you start with your story, Dr. Pruthi, you touched on some of the medical therapy. Let's take a second just to introduce what the TIF procedure is, and then we'll have Delilah kind of talk about her journey and how she was introduced to the procedure as well.
Very good. Now, we have been talking about the widening of the diaphragmatic hiatus, lower esophageal sphincter pressure, and hiatal hernia. And see, also normally there is a small portion of the esophagus in the abdomen. So during the breathing and after eating, so that kind of works as a valve so that it gets compressed and contents don't back up. And in patients with GERD, that valve is effaced, so that valve is reduced. Now, how can we reconstruct these sphincter valves and reduce the hiatal hernia size? So we have to intervene surgically. Previously, we used to do Nissen fundoplication, where with the laparoscopically or with open surgery, they used to make the sphincter stronger. So now, with the new procedure, TIF procedure, is called as transesophageal incisionless or transoral incisionless fundoplication. That means we can go through the mouth with the instrument that is new approved by FDA, made by Endogastric Solutions. So we go in and we can put some staples or fasteners around it and wrap the stomach, fundus of the stomach, roof of the stomach around the esophagus to enforce it and pull the esophagus down in the abdomen and fix it there. So that creates a esophageal junction that is stronger, gastroesophageal junction that is stronger, and prevents the acid from backing up. So this can be done endoscopically only, but if the patients have hiatal hernia, then we need to fix the hiatal hernia surgically. So then this combined procedure called as hybrid procedure, where the surgical colleague, surgeon, will go laparoscopically or robotically. They will fix the hiatal hernia, and then gastroenterologist, I go in there and make the sphincter valve and do the fundoplication wrap. So it's a combined procedure, works really good.
Very nice. Thank you for that. I think that gives us a great segue to Delilah and your story. From what we discussed early on, you were saying that you had, in fact, a hiatal hernia and reflux. So we'd love to hear your story. How long did you struggle? When did you finally decide to take action? How did you meet Dr. Pruthi? All of it.
All right. Thank you. Thank you for having me here. I'm very thankful to meeting Dr. Pruthi. He's a life changer for me.
Thank you.
Yeah, I've had this GERD for over 20 years. I've been struggling with it practically all my life. I think if you're watching, you can relate to, I've tried every PPI out there. I've seen at least 10, gastroenterologists, internal medicine doctors, and I haven't had anyone to really give me a solution. The basic solutions: diet, not eating certain foods, um, you know, pillows, raising your bed, just different things that you struggle with day to day, and it gets to the point where you do the diet, you do the exercise, you do everything, and you're still not getting any better. It's just not a good way to live. If you do happen to eat something that you're not supposed to eat, you pay for it at night. You have to stop eating after a certain time. You can't eat any longer. And just when, like Dr. Pruthi says, when the acid does go up your esophagus, it burns. It can burn your throat, and the pain is just horrible, horrible. Even water. It got to the point where if I drank water at night, if I got thirsty, I had a choice: drink water, or stay and get acid in the middle of the night, or go to bed thirsty. And that's no way to live. I just had it. It was not a good way to live. I've always been searching for something, and I happened to get something, actually, an email or something, where it was for a trial for GERD, and it happened to be Dr. Pruthi's office. Now, I didn't qualify for that particular trial, but he did an endoscopy for me, and he afterwards, he came over to me and he said, "Listen, I'm sorry you didn't qualify for this, but come and see me." He gave me his card. He goes, "I think I can help you." And I said, "Oh, okay." So I eventually made my appointment. I went to see him, and I read about the TIF procedure because I looked them up. I did some research, and I said, "What's out there?" And I did some comparisons. I actually went out there and then researched to see what was out there. And even some of the, I think it was John Hopkins has a really good program for acid reflux, but it doesn't compare to the TIF. When I looked at it, I thought, this is for me. I'm willing to do this. It looks promising. And I can tell you that's been a life changer. I did it less than 3 months ago. And even right after the surgery, for the first time, I was able to lay down and sleep without any pillows, and drink water at night, and all the water I wanted. And haven't had any acid reflux since then. And I love it. It's been wonderful.
Oh, that's amazing. Thank you so much for sharing that.
Thanks for sharing that story, Laila. And then she has been off of PPI therapy. Actually, after we finished the wrap and finished the surgery, next day, she said that no regurgitation, no acid reflux, no burning is happening.
No.
So we stopped the PPI therapy.
Yep. Yeah. So he asked me, "Are you taking it?" I said no, but I feel like I have to. I said I took one, and I didn't know why. I just took it because it says stop, don't stop taking the medicine until your doctor tells you. But I said, well, I don't want to take this anymore. I don't have the need for it. And they kept calling me, "You want your refill?" I said, no, no refills for me.
It was probably very freeing to say, no, I don't need those anymore.
Yes. And ever since then, it's just like anything else. It's something new in your life. I think I always compare it to some people who get like a transplant of anything. You want to take care of it. And, I even asked Dr. Pruthi, "Are you sure I can't tear this? Can I eat this? Can I eat that?" He goes, "I put extra staples for you." So it was great. It's been very good. I'm very happy.
Extra love added, huh, Dr. Pruthi?
Yes.
Delilah, thank you for that story. Tell us a little bit about your recovery. I know a lot of folks are interested in what is entailed in the procedure and what it's like recovering after. Can you talk a little bit about that?
Sure. So they did tell me the recovery was not going to be easy. They gave me a strict diet that I had to follow. And I looked at it and I said, oh boy, I don't know if I can do this. But, if you've been dealing with GERD for a while and you're just tired of it, you want a different lifestyle, the diet process that they put you in is nothing. It's very doable. It's the first 2 weeks was the hardest because you're on a liquid diet, but you have to keep in mind that you want to make sure that you have that heals, the valve that he reconstructs, it heals properly. And it's so crucial. The first 2 weeks are so crucial that, just follow the diet. It's, it's easy because you're not even as hungry as you think you're going to be. So you follow it, you're good, and at the same time you lose weight. So it's really good. Yeah, it's
The
not
plus.
Yeah,
That's, but we don't promote it as a weight loss procedure, though.
No, it's not a weight loss, but if you just follow it, it's important that you follow it. It's not easy, but you have to keep in mind that if you want it to be successful, you want to get off the PPIs, you have to stick to the diet. You just have to, and it's not, like I said, if you want to get off the PPIs, do it and you'll be fine. I had success with it. Every day I kept thinking, I want this valve to be healed. I want it 100% heal.
Yeah, we have a diet chart that we give every patient that tells them first week what food items they can consume, second week, third week, fourth week, and that's how they progress. And if they follow that diet chart, and it works pretty good.
That's wonderful. Well, it obviously worked for you, Delilah, and you're smiling and you're doing well. Do you have any favorite recipes that got you through that recovery time that you want to share?
I guess the first week was, just I did water and and teas and broths. So, just do that, and like I said, you're not as hungry. So just sipping throughout the day, you're good. And then softly, slowly introduce the like Dr. Pruthi said, there is, week 1, week 2, and you slowly introduce other foods. I think when you get to like third or fourth week, when you introduce like mashed potatoes, and you're so happy.
Yeah.
but it's not really, for me, the smoothies, I think it's the biggest thing. Adding protein to your drinks. You just, it just becomes a habit after a while. It's good. That's what I did. Mm-hmm.
Wonderful. Thank you. What would you say that this procedure, as far as what it gave back to your life, how would you tell the folks watching?
Well, for one is, of course, no more pills, because if you think about the pills, them themselves you don't know what's going to happen in the future, what it's doing to your body after so many years of taking those pills. Secondly, you have to really consider about the acid that keeps burning the lining of your esophagus over time. If that doesn't stop, it's going to result in other problems that can be, fatal. So you really have to stop and think, what is it I'm doing with my body? And if you're not the person that really can control your diet, because like Dr. Pruthi said, even controlling your diet, it's like the mechanical part. There's nothing you can do. That's broken. It's inside. It's broken. You got to get it fixed. And if you have someone like Dr. Pruthi of this procedure that can help you, why not do it? Because on the long run, pills or no pills, that acid will burn into your esophagus. And that's what scared me the most, because I said, I don't want to end up with cancer. So I have to do this.
That's a very good point, Delilah, you brought up. As the chronic acid reflux continues, it damages the esophagus lining. It can turn into Barrett's esophagus lining. That can eventually turn into esophageal cancer. So we have seen that the esophageal adenocarcinoma, the cancer rates are going up slowly over the last few decades. And we think it's probably related to the acid reflux, because our diets have changed. Most of the diets now are high sugar, high fat, a lot of additives, and those things reduce the sphincter pressure, and the reflux gets worse. So over the years, we have seen that acid reflux more severe, and more people getting the disease process and getting the complications.
Yeah.
Thank
People
you for
don't
sharing.
realize that even water, the kind of water you drink, it has acidity levels, and even that can make your reflux even worse. So.
Yeah. And when water is a problem, what's the quality of life at that point? So it's interesting to know what your drivers were to go do something about your condition. And we're so grateful you were able to find Dr. Pruthi and find some reflux relief through the TIF procedure and your experience. We just can't thank you enough for sharing your story. So many folks are just like you, struggling for so many years and not really knowing what is out there for them. So it's wonderful to hear your story, and we appreciate that. And what you brought up was something we didn't quite cover, and that's, you know, PPIs, potential long-term side effects on staying on them. We hear a lot about that, you know, dementia and some other things that you'll hear in the news that are potentially related. So folks are sometimes concerned.
Mm-hmm.
And then the other disease progression and what it could potentially lead to if you don't get it managed and controlled.
Yep. Very true.
Yeah, so we're just
I'm just happy. I'm very, very happy. Different lifestyle. I don't have to worry about taking medicine. And, you know, I just, not that I can eat anything I want, but, you know, but if I do eat something that normally I stayed away from before, even if I have it like maybe once here in a blue moon, it's not going to give me acid reflux, which is what I like. You know, I think I mentioned to you, I had a glass of wine the other day and I was like, I don't know if I should have this. And I had it and I was like, oh my gosh.
I can have another.
It's like, you know, it's like you're free again. You feel like you have a life back. So thank you, Dr. Pruthi. I appreciate it.
Thank you. Thank you. I'm glad you came and you brought a different light in our life and on our practice and clinic. She came as a research patient. It was very interesting.
Oh,
Because
I'm promoting the TIF everywhere I go.
Because we do research on reflux disease also. It was interesting.
Each experience is different, and every patient is different. I think you both touched on the importance of just getting checked, getting evaluated, so that you know that you know what's going on, and then working with someone like Dr. Pruthi to find what's right for you and what works for your specific condition. I'll just pause for a sec to turn it to Karen. Do we have any other questions coming in, Karen, that we want to ask either Dr. Pruthi or Delilah?
We do. We have a lot of questions. I will condense some of them, but we've got one question is, will I still need to take medications after surgery?
About 80% patients are off PPI therapy and rest of them reduce dose significantly.
Wonderful. We also have a question. Would GERD cause me to cough a lot for no reason? Why?
Yeah. There's cough is one of the extra esophageal symptoms for GERD. So when the acid fumes rise up, they irritate the voice box and larynx and upper airways, and people get chronic cough. Yeah, it's very common.
And then I have a question. How long or on average does the post-procedure diet last before you're eating solid foods again?
We have a diet chart. Maybe let Delilah answer that question.
You know, it's quicker than you think. The first, like I said, the first week is all liquid. Second week, you can start introducing a little bit of smoothies, some protein in there, so you really don't feel hungry. Let's say about the third week is when you start getting a bit of solid food in there. By the fourth week, you're good. So it's really, I think it was a good 32 days, about a month, and that's when you can start introducing more solids. But a month and a half, you can start eating almost anything you want. You just have to be careful what you eat.
Yeah, I agree.
And your body will tell you.
1 month, people are back to their diet. Yeah.
Mm-hmm.
And we had another question. What about exercise?
Yeah, we tell them to take it easy for first month, and then they can do, because even though we don't cut people from outside, but there's a lot of work goes inside. About a month recovery time, and take it easy.
Wonderful. And we have one more question. How long does the TIF procedure last, and can it be redone if needed?
Yes, the procedure itself, if there is only TIF procedure, then about an hour. If TIF combined with hiatal hernia surgery, about an hour and a half to 2 hours. It depends on the experience of the surgeon and the gastroenterologist and the team. So we have a good team now. Nurses are trained. We probably have done about 100 cases. Nurses are trained, the technicians are trained, assistants are trained now. So everybody knows what step comes next. So everybody just does their job and move on. About, I would say, under 2 hours, we can get them out of the OR. And then we keep them in the hospital for overnight. And then next morning, if everything goes well, and we do the swallowing test, and then we let them go home. It's overnight hospitalization. Mm-hmm.
Thank you. And we did have a couple more questions come in. One is it normal for somebody to start having symptoms a year after their last EGD, and should they go back for another test?
Yes, I didn't answer your previous question completely yet. The question was whether we can redo the TIF or not. So it can be done if the fasteners become loose or patient is getting symptomatic again. I can go back in and wrap it more. So it's very easy. Then what's the next the question that you have?
Yeah, apologies. I thought you had finished the question. Our question that we have is it normal for somebody to start having symptoms a year after their last EGD? And should I go back for another one?
It depends. And the EGD per se doesn't cause reflux symptoms, but depend what the reason was. The previous EGD was done to look for ulcer or something else, and they did not have acid reflux at that time. Now they have new symptoms, acid reflux, so then they should go back to their doctor and get evaluated. And then ask for the hiatal hernia, ask the right questions to the doctors also. I always encourage my patients to write down the questions, because everybody is busy, the doctors are busy, they're running around, and clinic time is short. We have limited time interaction. So I always encourage my patient, write the questions, bring a piece of paper or on their phones. Okay, ask me all their questions.
Thank you. And then we have one more. Who is an ideal candidate for the TIF procedure? And I think they're asking a lot of what tests or diagnostic tests do they need to do prior to seeing if they're a candidate?
So the patient who have chronic acid reflux, and the sphincter is not working properly, there's a large hiatal opening there, or they have hiatal hernia, and they are good candidates for TIF. Now, people who are controlled with medications, they say, what, I'm on PPI therapy and my symptoms are under good control, but I don't want to take the medicine for the rest of my life. The youngest patient that I have done TIF on, I think, is 19 or 20. Now, he had this hiatus opening was bigger, sphincter was not working properly, and I can't commit to him for PPI therapy for the rest of his life or any acid reducing therapy. And he's young, man. He has life ahead of him. He wants to do exercise and go to college, whatever he wants to do in his life. And so we did TIF on him, and he's doing very well. It's off PPI therapy. Went to college. He's in engineering school.
That's wonderful.
Yeah.
That's fantastic. Yeah. I think we've answered most of the questions, and I'll turn it back to you, Lynn.
Wonderful, thank you. These are great questions. We get a lot of interest in diet, recovery, what they're able to do, who's a candidate, all of that. So I think you both covered that so well this evening. We always like to ask if I'll ask both of you, Dr. Pruthi, and I'll ask you too, Delilah. If there's one thing you were to tell someone who's maybe on the fence and has been hesitant, what would you say, Dr. Pruthi, to someone like that?
If they're hesitant, then find out why are they hesitant. What do they want? That's the difficult question to ask yourself. What do I want?
Yeah.
So ask yourself, what do you want? If you think, okay, the time is right for me to get the things done, go talk to the doctor, ask them all the questions, satisfy your queries, and make a well-informed decision and go for it.
I love it. And Delilah, how about you? For a patient who might be on the fence about moving forward, getting a consult or even getting some kind of intervention like you did, what would your best advice be?
I would go back to you're living your life and you're miserable because it is misery. And how much longer do you want to live like that? For how much longer, you know? And also, you know, you got to think about again the medicine you're taking because if you, it's those PPIs, even if it's over the counter, whatever it is, you're still putting medicine in your body that you may not need to. So for how long are you going to do that? Because when it gets chronic, and if you are chronic, how much longer do you want to live this when there is a procedure out there that has been created that can, you know, take you off the medicine, that can give your life back to you? So what is the hold up? You know, it's a, you have, like doctor said, doctor, you have to find out what that is, but don't be scared if the procedure is there. You know, I was scared. I didn't know what I was getting myself into, but I, you know, was thinking about the alternative. And now that I went through it, I can tell you that don't be afraid. You should do it. It's well worth it. Take your life back.
Oh, couldn't have been said better. And thank you so much, both of you, for sharing your expertise, Dr. Pruthi and Delilah, for sharing your story. We have an app, a mobile app out there too, for anyone who's interested in learning more about just reflux in general. It's loaded with videos and lots of information. You can download that on wherever you go for your apps. It's called GERD Help. It is a complimentary app that you can download, and you can use it to index your GERD journey. Use it as a diary, and you can use it to have those discussions with your doctor. Reference back the last 30 days, how problematic your reflux has been, and start that dialogue with your physician to make sure that's part of your care plan. And if you're not in the area where Dr. Pruthi is, it's Lancaster, California, right, Dr. Pruthi?
Yes.
Lancaster, California. If you're outside of Lancaster, California, we also have a physician finder on our consumer website, which is also chock full of information about reflux and the TIF procedure. It's called gerdhelp.com. You're welcome to go there. In the top right corner, there's a physician finder button. Plug your state in, your zip code, and you can find a doctor just like Dr. Pruthi to help you as well. I can't thank you both enough, Dr. Pruthi, Delilah. Thank you, Karen. Thank you for all of you for being here and making this episode so educational and special.
Well, you're welcome. Thank you for having me.
Thank you. Thank you for arranging everything.
You're very welcome. It's been our pleasure. And for those of you joining us tonight, thank you again for your questions. We hope this was informative. Please share it with your family and friends. And you can join us here every Tuesday for our Tip Talk Tuesdays. And we'll see you next time. Have a great evening, everyone.